Good afternoon and evening. The Global Pediatric Surgery and Health Policy and Advocacy Committees are excited to bring you part 2 of our Social Justice Symposium, focused on disparities in access to care. My name is Jay Krishnaswamy from Oregon Health and Science University. Last week, we heard the considerations around access to care for the pediatric trauma patient from Drs. Garcia, Walsh, and Shekerdimian. Today, we will focus on disparities in access to care for the surgical neonate. Representing the urban perspective will be Dr. Larry Moss. Representing the rural perspective will be Dr. Ellen Reynolds, and our global view will be supplied by Dr. Robin Petrose. Comprehensive health coverage is a WHO goal. Coverage should include health promotion without financial risk and with universal access to care. Not all countries have achieved this goal, including the United States. Access has 3 critical components: physical accessibility, so that good health services are within reasonable reach of those who need it; financial affordability, which is a measure of people's ability to pay for services without financial hardship; and acceptability, which involves people's willingness to seek available services. Lack of access due to any of these 3 aspects leads to unmet health needs, delays in receiving appropriate care, inability to get preventative services, financial burdens, and preventable hospitalization. Access to care varies based upon the social determinants of health, which refers to a person's race, ethnicity, socioeconomic status, sex, disabilities, sexual orientation, gender identity, and residential location. We'll now ask our guest speakers to discuss some case scenarios to illustrate the consequences of poor access to care for the surgical neonate, with a focus on how to overcome these issues. Dr. Petrose, there's a newborn with an anorectal malformation that has arrived to the hospital that you're working at internationally. I think we're all familiar with how these kids present in the typical bigger center in North America. Can you tell us a bit about the setting in which you've encountered such patients globally and how they can present, and therein what some of the accessibility challenges are?
Thanks, Jay. Firstly, given this unique online platform for APSA this year, I think it is very important for me to acknowledge that the majority of my training and practice is in North America. And while I spend a considerable amount of time in global surgical care delivery, research, and education, the real experts are the pediatric surgeons who are practicing full-time in low and middle-income countries. And so I really look forward to the discussion in the comments that this online forum allows that may provide some insight. What I do know is that anorectal malformations are one of the most common neonatal conditions cared for by pediatric surgeons in low and middle income countries. Unlike other neonatal surgical conditions, anorectal malformations are not immediately life-threatening, but do require specialized pediatric surgical and anesthetic care. Their initial management highlights the disparities and challenges with emergency neonatal surgery in many low and middle income countries, and the staged repair highlights the challenges inherent in expanding the saving of lives to the saving of lifetimes. When we look at accessibility as the first barrier to care, I've divided this into 3 categories. First, accessibility is impacted by the specific geography of a location. Urban and rural populations have different accessibility challenges. Was the baby born at home or in a health center? What transport is available? Second is training. Many of these babies seek care when they have feeding difficulties. And so this is at several days of life rather than being noticed on a newborn examination. Is there skilled care available at the district hospital level, for instance, to perform a colostomy? I remember in my training doing a rotation in Kenya and seeing older kids with colostomy complications from transverse colostomies performed by general practitioners. And one of the important lessons I learned is that before criticizing technique, I had to acknowledge that that GP saved a baby's life. Third is resources. Once a neonate makes it to a center with pediatric surgical capacity, Is there anesthesia availability or operating room availability? If a baby has arrived late with respiratory complications or associated comorbidities, what is the availability of other services or intensive care unit? There are numerous other barriers to resources for ostomy care, dilations, and surgical access and backlog systems for definitive repair. So, despite the fact that I said an anorectal malformation may not necessarily be a fatal condition, a systematic review out of Nigeria found that 20% of neonates with anorectal malformations who seek care die. That number is likely higher, as only 3% of pediatric patients in low-income countries are estimated to have access to safe surgical and anesthetic care. Let me repeat that. Only 3% of pediatric patients in low-income countries are estimated to have access to safe surgical and anesthetic care.
I think those are really eye-opening issues. What about from an affordability standpoint? What are some of the individual and system finances at play globally? And are there specific social beliefs or stigmas that can affect the acceptability aspect of their care? And what are the solutions to these problems?
Those are great questions. I think there are several points of affordability. The first, can the family afford transport to a health facility? Can they pay for the operation? In many settings, if the family cannot pay for the materials for the operating room, they cannot go to the operating room. Sometimes the child cannot be discharged from the hospital until the hospital bill is paid. You can imagine the challenge for families who live on less than $2 a day or are primarily agrarian. Additionally, in-hospital care must also be provided by a caregiver. This is often the mother, who is then away from other children and responsibilities, as well as needing to feed herself. One of the challenges I see with neonatal surgical conditions is that not only the stress of having a sick child and being away from other family members, but also poor nutrition and availability to pay for that for the mothers leads to breast milk drying up. On a larger scale, how is the health system financed? In countries like Rwanda, where I work, and a national health insurance plan exists, advancing neonatal care is supplemented by government insurance. In other places, non-governmental organizations, faith-based organizations, or missions provide free care. But this can bring into question the sustainability of care. And other times, communities draw together to provide financial support. The long-term solutions to supporting those communities include advocacy at an international and national level to include access to surgical care as a component of primary care. This push by global surgery advocates over the past 5 to 10 years is seeing the creation of national surgical, obstetric, and anesthetic plans that help to include surgery in the future funding and development plans of ministries of health. In terms of acceptability, functional outcomes of anorectal malformations carry significant socioeconomic burdens. Colostomy complications are common, and resources for stoma care are scarce. Dedicated bowel management programs are not routinely available. Those that are rely mainly on enemas due to the availability of water. There are significant challenges for the family. A survey out of Uganda found that nearly 50% of families with a child with a colostomy had a spouse leave, and over 90% had to give up another means of work or income generation. A study in Honduras found that 50% of school-age children with a stoma did not go to school. A colorectal clinic in Johannesburg, South Africa, looked at the specific challenges in their patient population and found that patients had additional health issues or exposures and poor access to proper sanitation. Additionally, definitive repair is often delayed. This obviously impacts families as well as long-term function. And so when we look at acceptability, it is important to remember that quality of care, not just access, and outcomes are fundamental to improving care. Global collaboration and partnership is key to discussing solutions. Therefore, I wanted to turn to some of the real experts for how they are challenging care and improving care on the ground. The first example comes in a paper from the African Journal of Pediatric Surgery out of Nigeria that describes a technique for using local anesthesia to perform colostomy in neonates. The next article comes out of Kenya and describes the use of transperineal ultrasound for anorectal malformations to determine how close they are to the perineum in comparison to a high pressure distal colostogram, which often is not available. And in terms of looking at creativity in stoma care, this article out of Bangladesh describes using local resources and innovation. Overall, I think that developing global solutions really involves advocacy, funding, because these really are conditions of poverty, and to develop sustainability, training, innovation, and a focus on outcomes. Thank you for the time to discuss this.
Hey, that was great, Robin. Thank you. So, Dr. Reynolds, for the same patient with anorectal malformation, we know that many of these issues that we've just heard about apply in a different scale and a different way in rural areas of the U.S. Which of those ring true, and what specific barriers might your patient with anorectal malformations encounter in seeking, reaching, and receiving care in the rural setting, and what are some of the unique ways that these issues are being addressed?
Yes, well, thank you for inviting me to be part of this discussion. A little background, I work at St. Luke's Children's Hospital, which is quite geographically isolated. We are 300 miles radius from the nearest tertiary care center, whether it be Salt Lake, Portland, or Seattle. We're the only tertiary care center in Idaho, and due to insurance constraints, people especially want to stay in Boise. So I've used a place called Haley, Idaho. It's about a 2.5-hour drive from Boise. It's a farming community, mostly migrant workers. And of course, if a male is born in this community with anorectal malformation, that's usually easily recognized, and they can be transported to Boise for further care. A female, though, we can often see that these are delayed diagnoses. In our rural communities, there's often advanced care providers or family practice physicians who are not that familiar with these malformations. They may just take a peek in the diaper and note meconium and assume that the child has a patent anus. At times, these are delayed in getting to us as well. But let's say that for the male infant, we do have a quite good maternal fetal transport team. Will come and bring the infant to Boise. If the mother, though, has had a C-section or is just recovering from labor, there may not be any parent that comes with this child or family member to the NICU, and thus the infant is separated almost immediately after birth from the family. And it may take a day or two before that family can even join the infant. And so sometimes when we're planning surgical care, we're obtaining consent over the phone. It's difficult to explain to the family what their child needs because they can't see the infant, and that in terms of acceptability of care can be a problem. In addition, the child may be in the NICU for at least a week or so, depending on the care, and then we need to worry about follow-ups. As noted, just the initial transport, the baby may get the care, but the family is not necessarily included. Continuing with that, the family may not have access to a car. There may be only one car in the family. They may not have money for gas. Usually the father would have to take time off from work, leading to lost wages and further difficulty in just physically getting there. They may have to get childcare for other siblings. We do have some inclement weather, not infrequently. We may not be able to fly. And often if we're going to send an ambulance, the ambulance has to start in Boise and then reach Haley or their destination, pick up the infant, and then return, thus further delaying the care. There's only one other level 2 NICU in Idaho, which is Idaho Falls, about 4 hours away. So once the infant comes into our NICU, they are spending the rest of their NICU stay with us. If the child's born prematurely, that may be 4 to 6 weeks, depending on their other comorbid factors. And even if there is a NICU that could accept the infant in return, insurance won't pay for that back transfer. So family, even if the baby is just feeding and growing, has to be able to stay in Boise. For financial affordability, we've already touched on the cost of lost wages, childcare, the costs of travel. Fortunately, most newborns will qualify for Medicaid, and that can be applied retroactively So the cost of the hospital stay can be covered. Of course, there are families with self-pay with not a low enough income to qualify them for Medicaid, and a NICU stay can be extraordinarily expensive even just for a week. We do have a Ronald McDonald House where families can stay. However, if you have a prison record, you won't be able to stay at the Ronald McDonald House, and that's not an infrequent problem either. In addition, stoma supplies are expensive. They may be difficult to get. Medicaid only covers a certain amount per time period. So family may run out, they may not have enough, or they may not even have the type of bag that would actually fit best for their child. One of our solutions for this is that we ask families, and they often even donate without us asking. As soon as the child's colostomy is closed, they bring us the extra supplies that they might have had left. And if they haven't expired, then we pass them on to the next family. We do provide our families with Hagar dilators, and we ask that they return them when they move up to another size, and we can then recycle these as well. Another common issue is that since they are a distance away, that if there is a problem with the infant, they would go to their local emergency room or healthcare provider, and often there is not the education there or the expertise. For families to accept and seek our care, we have several factors that can be a problem. They're often lower socioeconomic families, often non-English speakers, so the language barrier is present. They may have undocumented status, and they're very reluctant to present to the healthcare system for fear of retribution against that. They may have had previous negative experiences with healthcare. And if there's been a delay in diagnosis, there is certainly a mistrust of health caregivers, especially in their community. And then it's difficult to get them to continue on with the child's care. For example, bowel management problems or other interventions that can be helpful for the child's quality of life. There's, of course, the stigma attached with colostomy or ongoing fecal incontinence issues following definitive surgery, and the family may be very reluctant to come back for further, say, bowel management clinics or biofeedback programs, anything that could help the child. They just don't want to seek further care because of the time, distance, and cost. So the solutions, we have some solutions in place. Of course, we can always improve, and we are working towards that. We have dedicated social workers. We have very good patient care coordinators in the NICU to help set up the follow-up that these families need, make sure that they have the supplies. We don't often have home health care in the locations that we need it, but it is, again, important for us as a surgical team to very much listen to these families to understand what their resource needs are. And just as Dr. Walsh mentioned, accept what the family can do. For example, if the family can only do a dilation once a day because no one else is at home to help the mother do it and she's frightened of doing it, then let's just do it once a day when the father can be home, and instead of insisting twice a day. When we make their follow-up appointment, let's just not give them, okay, we need to see you in 2 weeks' time. Let's say, is there a day of the week that works better for you? A time of the day that you can get here? Even if it's not my own personal clinic, perhaps I can make time to come in at a different time, or one of my partners can see them. We've had telehealth in place. Of course, it's markedly improved at a rapid pace because of COVID. And we are trying to do more visits over the phone. We do often note that people don't have internet access, so that can be a bit tricky, but it's certainly improving. We do have outreach clinic located where a large majority of farms are about 2 hours away from here that we go to once a month. So we pay attention to the location of the family and have them go to that clinic. And we are also starting another one in Idaho Falls, which is 200 miles away. So in summary, I would really like to stress the importance of personal care for each of these families. As a surgeon, we're not just the technician. We need to involve the family in the care of the child, of the infant, to have the best outcome. And if we establish that personal relationship with the family, they're more likely to reach out to us when they have a problem and to understand what further medical care can be offered them. Oh, thank you.
So Dr. Moss, from an urban perspective, we often think of the large children's hospital as kind of being the pinnacle of care where access to care issues for such patients don't really apply. But these same issues of physical accessibility and affordability for the patient can be affected in different ways in a big children's hospital. What are the factors at play in those urban settings?
Thank you very much, Jay. It's a privilege to be here, and congratulations to you and your colleagues for asking hard questions, because these are important issues that we should be talking about. Anorectal malformation is a complex congenital anomaly. It requires tertiary and quaternary care. So you would think, what a stroke of luck to be a baby born down the street or a short car ride away from the tertiary quaternary children's hospital. That's ideal. It's a perfect match. But in reality, not so much. And there are significant accessibility problems. I'd start with the concept that the outcome that this child is going to ultimately end up with is due to far more than the quality of the tertiary and quaternary care provided. So you can rest assured that that child will get to the big children's hospital, will have a high quality operation, and if the child goes to the ICU or needs an MRI or needs an ultrasound, it'll be done well. But there are two critical aspects that will affect this child's outcome that we can't count on having done well. The first is all of the supportive care and the other visits necessary to achieve the outcome. We've learned very clearly from the high-end anorectal malformation centers that have developed in this country that a good operation is only the beginning of the outcome. And the supportive care, the dilations, the bowel management, everything else that goes along with care is critical. Not so likely that the child from a disadvantaged background or the child that lives in proximity to that hospital is going to receive those services in the same capacity or the same quality. The other major factor that impacts outcome is the social and the environmental circumstances in which that child lives. And if we're not able to address those, the tidal wave of that will overcome any little bit of difference we can make in the outcome by the quality of the operation. So the support structure, or all of the supportive care in our system of care in the United States, is unequivocally geared to the privileged. I've listed just a few reasons here, and we don't have time to go into them in detail. Language barriers are not likely to be fully addressed. Timing of visits are a big issue for families who may work an hourly job, where even a simple, quick visit to the specialist's office or even the primary care doc's office is lost income and perhaps off the table. Furthermore, as specialists, our relationship with the primary care doc and the primary care doc's involvement in that child's care is likely to be very different for the privileged child versus the disadvantaged child. So, like true of many things in our system of care in this country, care is going to be primarily driven by what the system does well, and a lot less driven by what the patient and family needs most. In the United States, most children have medical insurance. For half of children in this country, it's Medicaid, and for the other half, or most of the other half, it's commercial insurance. So you think, well, we're in pretty good shape. These kids are covered, especially if they have a complex problem. Again, there's a paradox here, because the finances cover the tertiary quaternary aspects of the care. They don't cover the rest of the care. So again, those aspects are likely to be well provided and high quality, but the remainder of the care, not so much. There was a paper published recently out of the Memphis group, which looked at the investigations for associated anomalies in patients with anorectal malformations in essentially rich patients versus poor patients. And the paper found, well, the quality and the frequency of those investigations for things like MRIs and spinal ultrasounds and renal ultrasounds is the same, and there's no disparity of care. Sounds like good news. Well, of course, it's going to sound like good news when it's reimbursable services. When the institution gets paid for the MRI or gets paid for the ultrasound, it always gets done. But when we're talking about attention to the dilations and frequent non-reimbursed follow-up visits, frequent phone calls, a greater depth of care, there's a big, big disparity. So what will hold back the outcome or be a negative drain on the outcome for the disadvantaged child with an anorectal malformation? Largely, it has very little to do with the technical quality of the operation or the specific anorectal malformation care. It's the larger circumstances in which that child exists. We know education, for example, has a massively greater impact on length of expected life than any medical factors, whether you have diabetes, whether you have hypertension, whether you have metabolic syndrome. So you imagine you get all the way down to a congenital anomaly, that ends up being a trivial factor in the overall lifespan and medical outcome that that child will achieve throughout his or her life. Similar data around housing. Adverse childhood experiences. You add a few adverse childhood experiences in the mix, and the quality of the anorectal malformation care becomes secondary or trivial when you look at the actual outcome. So answering this question about outcomes through the lens of the quality of the specialty care is necessary. We need to do right by these kids and do good operations and provide good quality anorectal malformation care, but it's not sufficient because it exists in a larger context. And unless we're willing to look at the larger context and do something about it, we're going to be swimming against the tide.
So it may not be obvious that there would be issues around acceptability in the big city setting, given the plethora of information that everyone's exposed to, but urban settings are some of the most diverse economically, racially, and otherwise. And what are some of the unique acceptability challenges, and what are some of the solutions to these collective issues?
Very good question. We're recording this session on the days where we're in the height of the violence and social unrest around George Floyd's death. So I don't know where we'll be when the session finally gets broadcast, hopefully in a better place. But we're seeing a very bright light shined on the deep mistrust that disadvantaged people in this country have in our law enforcement system. And I'm going to suggest that the distrust of our medical care system runs just as deeply and is just as much of an issue. In aggregate, our health system does a very poor job for the disadvantaged population. And if you look at aggregate data, take one example, infant mortality. It's over 5 times higher in disadvantaged neighborhoods than it is in privileged neighborhoods. That's a massive difference. And even when you correct for zip code differences and socioeconomic differences, there's huge racial disparities. African-American infants have a dramatically higher rate of infant mortality than white infants, even when you take all the other correctable social factors out of the equation. So there is a justifiable mistrust of our health system in disadvantaged communities, and that's on us to do something about. Exactly what we do about that, it's outside of the scope of our discussion today, but I'll suggest that it's very important. There's a number of legal concerns. For example, the public charge rule, work requirement barriers to Medicaid, which might discourage families from seeking much needed care. You could go on and on. These are baked into our system and they're clearly going to influence behavior. There are cultural challenges around anomalies which involve the genitalia, and I've listed a few of these on the slide. Again, we're not going to go into these in depth today, but they exist and they're real, and they're more significant in families from disadvantaged areas than they are in families from privileged areas. So what are the answers to some of these very challenging problems? I went into my current role because so many things I saw as a surgeon that were wrong with our health system. I wasn't in the optimal position as a surgeon to influence. Surgeons need to be at the table, but it requires a broader conversation. So My answer to solutions is about our overall healthcare system in the United States. Until we align financial incentives of the health system with the patient, we're not going to solve any of these underlying problems. The health system in the US is a roughly $3.5 trillion juggernaut, and virtually every penny of that $3.5 trillion goes to pay for the opposite of what we're trying to buy, which is health. We don't pay for health. We pay for volume and complexity of medical services. We pay for tertiary and quaternary care. So we do that well, but we do everything else very poorly. Until we can properly align those incentives, we're not going to make much progress. Once we align those incentives, everything else goes away and everything else falls into place. So if you look at the slide, under our current fee-for-service system, we emphasize surgery and procedures. Move across the slide, imagine a pay-for-health system. Well, we're still going to emphasize surgery and procedures, and we're still going to do those well. But in the fee-for-service system, supportive care suffers. In the pay-for-health system, we're going to equally emphasize supportive care, because if we don't, we're going to get a bad outcome, and we're going to be financially on the hook for that outcome. So we're going to be falling over each other to do those things well. In a fee-for-service system, outcome is irrelevant to the payment. In a pay-for-health system, outcome is a core essential to the financial viability of the system. And if you don't get a good outcome, you go out of business because you got to pay for it. In a fee-for-service system, family social conditions don't really matter to the health system financially. We might care about it emotionally, or we might say that we do, but it has no financial impact on the performance of the system. In a pay-for-health system, the family social conditions not only matter, but matter more than medical care to the viability of the system's finances. So attention shifts from the 20% of health that is accounted for by medical care to the 80% of health that's accounted for by all of these other factors. So finally, in the fee-for-service system, the episode of care or the medical services delivered is the focus. In a pay-for-health system, health and outcomes becomes the focus. So I'll suggest in closing that anything we do short of that is rearranging the deck chairs of the Titanic. We need to align our incentives as health systems with the incentives of the patient and the family, and make that all about the long-term health and outcome the child achieves. Thank you very much.
So that was all about life and access to care issues, I guess, where we were 10 weeks ago. We all know a little thing called COVID-19 has kind of been in control since then. How has this changed access to care issues in your settings right now? Dr. Garcia and Dr. Moss, can you talk to us from the urban setting, how this has affected your access to care issues?
So thank you, Jay. We've lost, at the time of this recording, over 100,000 Americans to COVID-19. So it's an obligation to ask, what are we going to do to honor their memory? And what have we learned from this? And I'll suggest that COVID-19 can be the transformational catalyst to undertake the massive change in American healthcare that we just talked about a few minutes ago. We've learned a few things from COVID-19. First, our system, when it has to, can change incredibly rapidly. For example, at Nemours, take telehealth. We went from 50 visits a week to almost 2,000 visits a week in a matter of 2 weeks. So we're not so ponderous as we thought, and we can change quickly if we want to and if there's an imperative. We've also learned that our giant health system in this country is extremely resilient. You know, we took this giant $3.5 trillion juggernaut that we thought couldn't possibly change. We stopped it and we changed it on a dime, and that can happen. And there's a huge lesson to see that that can happen. And finally, COVID-19 showed us that there's massive waste in the system. All of these deferred and delayed procedures, especially in the adult world, but in the children's hospital world, a lot of them are not coming back, and they're never going to be done because they were unnecessary in the first place, and a bright light has been shown on that. So I would say this is a pivotal moment in American healthcare, and we should look at COVID-19 as the best opportunity we've had in our lifetimes to make necessary change.
So, Jay, I would look at COVID-19 as really unveiling something that many of us have really appreciated has existed for decades. And that is the vulnerability of disadvantaged individuals, and particularly individuals that live in disadvantaged neighborhoods. When we look at, let's say, the proportion of minorities, and I'm not just talking about African Americans, but also Latinos and also Native Americans, we see that even though they may represent a much significantly smaller percentage of the population, general population, they are in fact the ones that are more susceptible to infections and dying. And when we think about access to care, what is unknown is the number of people who die before they even get to the hospital. And we saw that evident in New York City as far as the impact of COVID, predominantly in some of the poor neighborhoods. But I want to come back again to the issue as far as really our health system. And that is that we can have the greatest health system in the world. But if people at a very young age are developing adult diseases, which is what we're seeing in these disadvantaged neighborhoods, frankly, I don't give a damn how good the health system is. These people we're going to be dying and much more susceptible. We see that as far as cardiovascular disease, where the studies have shown that children as young as 5 to 8 years of age, looking at the Fragile Family Study, have hypertension. We're seeing a premature development of atherosclerosis in children who have obesity. And we know that African Americans are the ones that are significantly susceptible to obesity, followed by Latinos, and then again the general, the population. So we have to look outside of the health system, and then looking at what I would call the social determinants of health, and what that represents as far as the drivers, and particularly the economic ecology, the degree of poverty that has persisted. As a matter of fact, it's worse now than it was 40 years ago. The children of the civil rights era have made virtually no advancement out of those impoverished neighborhoods that they were in 40 years ago.
Thank you. Dr. Reynolds and Dr. Walsh, can you comment on how COVID has affected your rural settings?
Sure. So one of the problems with rural healthcare is funding. And I think that the thing I worry the most about is loss of our rural hospitals and access to healthcare, even at our community health departments. So before COVID hit, 1 in 4 rural hospitals were financially unstable and thought to potentially be at risk of closure, and hundreds are closing. And the economics of COVID, being unable to bring in income for colonoscopies and procedures and the CPT codes that come with them, has financially injured so many of these hospitals that they are not going to be salvageable. So I worry that the access to care issues we have at the hospital setting are going to be compounded by the finances that follow COVID. And even a manpower issue exists. So for example, one of our county health departments, which has a grand total of 9 staff to do everything, one person was exposed. The entire county health department is closed until they can restock, restaff, and have people who are negative. So there's no healthcare of any type available in those counties. And that's a COVID phenomenon that we have to keep an eye on and figure out how we're going to work around it. I think that testing of children in rural settings is problematic. Sticking a swab into the nose of a small child is hard, and it's really hard if you don't have 3 people to tie him down, and it's really not very child friendly. So you thought shots were bad. Let me tell you, those kids think that these nasal swabs are the worst thing in the world. So the trust relationship when we're having to test them for COVID, the inability to get rural caregivers to look at our children. And then we, like many, have policies. You can't come in for your elective surgery unless you tested negative for COVID. So I have people continuing to push off surgeries that really ought to be done because they're not interested, willing, or able to get COVID tested. They can't drive 3 hours in, drive home, drive 3 hours back for the operation. And then finally, I think that the closure of the schools has really taken a hit to healthcare on top of all of it. Without schools, they don't have interaction, they don't have food many times, they don't have people in their community checking on them. And so that's a problem that's going to have long-term consequences for the rural children that I'm not sure we're going to overcome very well.
So I must say, though, I think we've actually been fairly fortunate in Idaho just because we were so geographically isolated and our hospital planned ahead. We shut down before we had any significant crisis here. The biggest issue now for us is the testing. We're requiring a negative test 48 hours before surgery. And of course, if you're in a rural community, trying to get that test is almost impossible. Our hospital has agreed that it doesn't have to be through their health system, so that they will accept someone else's negative test as long as it's the PCR. But that, I think, is a big barrier. We are finding that most people do want their surgeries, and they're very willing to come in at the drop of a hat when we call them and say, okay, we've got an opening, let's get you in. I think the one benefit has been this marked improvement in telehealth and really pushed for that. And we definitely need that in the rural communities. We still have the issues of no internet, no computer to do a video chat on, but I think that has been a marked improvement.
Great, thank you. Dr. Shekerdamine and Petros, how about in the global setting?
I think that from a global perspective, this is a global pandemic. And what we have learned or seen, similar to Ebola, is that global health impacts local health. This includes global health funding, training, sustainability, that if we're not able to invest in health systems around the world, we're just letting ourselves open to the next pandemic. Both locally and globally, it just reinforces that poverty is the strongest determinant of health and health outcomes around the world. And so this globally might be just the tip of the iceberg. And so as communities around the globe face the COVID pandemic, what's going to happen to supply chains? What's going to happen to healthcare workers? What's going to happen to other conditions that are not able to access care? Now, in some senses, a lot of our global partners are actually doing a better job than we are because the community health programs are better set up, the contact tracing and the public health system, because that's what has been strongest rather than the hospital system, it has been better set up. And so the other is that we have a lot to learn in terms of sharing ideas and solutions and innovations for cost-effective care, for how to properly contact trace and to build a public healthcare system that we are not as good at here as globally. But I think that the fundamental lesson is that unless we strengthen healthcare systems around the world and unless we address the issues of poverty and economic sustainability of healthcare systems, and as we've seen in our own healthcare system, that enhancing surgical services is imperative to the financial sustainability of a healthcare system. And so as we look forward, having a more global view as we look locally is going to be fundamental to facing the next pandemic.
I would echo all of the comments that have been made. Interestingly, as I was hearing everything, it was striking to me how, despite the variation in the settings and the presentations, there's actually similarities with regards to the issues as they pertain to the current pandemic. Yes, there are the acute issues with regards to the availability of medical care and the surge capacity, but I think all of us are saying that underlying this are the fundamental issues in the quality of health being delivered, in the ramifications of poverty that underlies all of this, in the need to have an overall healthier society and a healthier world so that we can overcome not only this current pandemic but any other stress to healthcare systems. And so the focus on preventative medicine, on increasing quality of health, on eradicating underlying poverty and paying attention to social determinants of health are the underlying lessons that we have to learn from this pandemic so that we can overcome not only this one, but most other issues in healthcare for the future.
Well, I think that brings us to the end of the session, and that's given us a lot to think about regarding the incredible challenges around care access that cross all these settings, and some of the inventive solutions that can really be realized if we keep at it. I know Ken and I have been very happy to have worked with you guys on this important session, and I want to thank all the panelists for a very stimulating and important session. So thank you very much.